So we started I'm Mattia D'Agostino. I'm from the University of Torino, and on behalf of the key opinion leaders in Harmony, that are Professor Boccadoro, Professor Sonneveld, and Professor San Miguel, I present you an update on the multiple myeloma pilot project we started 3-4 years ago to run this project. And our aim was to improve prognostication in newly diagnosed multiple myeloma. So to improve prognostication, we have to start from the standard of care that we have now in Europe. And the standard of care was published in 2015, and it was called Revised ISS. The Revised ISS is based on some biochemical values like albumin and beta-2 microglobulin, and this is the ISS. And then it adds to the ISS the value of LDH and cytogenetic risk. And as you can see from the cartoon, patients that are ISS1 and do not have high LDH or high risk FISH, they fall in the revised ISS1 group. Patients who are ISS3 and have or abnormal LDH or high risk FISH fall in the revised ISS3 group, and all the other combination falls into the revised ISS2. And this was published in JCO in 2015, and it is based on data from 3,000 patients of clinical trial data conducted from 2005 to 2012 in Europe. And then that report, as you can see, though in the down left of the screen, the majority of the patients, more than 60%, fall in this prognostic good to identify low risk and high risk patients, but the majority of the patients falls in the intermediate group. So we started from this database, and we started collecting data from the European cooperative groups using the European Myeloma Network as an umbrella and as an intermediate between European cooperative collected now more than 7,000 cases. And these are all newly diagnosed multiple myeloma patients and are all patients enrolled in clinical trials. We expect to receive soon also a few other 5,000-6,000 cases from UK and from our colleagues of Celgene that run some of the trials that approved the current standard of care regimens in elderly patients. So we expect to go up to 12,000-14,000 cases, and the main variables that we collected in the database was, of course, anti-myeloma treatment demographics, but also baseline diagnostic labs like creatinine, baseline prognostic factors like ISS, LDH, and FISH, performance status, response, and time to event endpoint. We decided not to go for a very complex database because we wanted to start very soon and to have data rapidly. And so we asked for very few variables here that were already available in all the clinical trials. So these are the patients that are already registered in the platform. As I told you, 7,000 cases, and I want to stress that the median follow-up of these trials are much longer than the revised ISS, because we have now 75 months of follow-up. And this is important because if you are going to look at prognostic variables in multiple myeloma, you have to have a long follow-up, especially if you want to look on variables impacting the survival of the patient. As you can see, fortunately for the patient, in the last years, the survival of multiple myeloma is increasing a lot, and that's why we need a long follow-up to identify the bad prognosis, the variables predicting a bad prognosis of our patients. So If we compare this data to the revised ISS data, we have now 7,000 cases against 3,000, 15 clinical trials against 11, and we go up to patient treated up to 2014, and the median follow-up is much longer, 75 months. And all patients received at least a novel agent that for myeloma people is an immunomodulatory drug or a proteasome inhibitor. These are the baseline characteristics of our patient, and as you can see on the left, almost half of our patients received a combination of IMiD and PI during their treatment. And IMiD is immunomodulatory drugs like thalidomide or lenalidomide, and PIs are proteasome inhibitors like bortezomib or carfilzomib. A few patients received PI only, and 40% of the patients received IMiDs. And 65% of our patient population then received, they were transplant eligible patients. So they received transplant, at least in intention to treat analysis. On the right, you can see the risk factors that are calculated in the revised ISS. We have seen them before. So ISS, LDH, and FISH. And as you can see, the missingness of these data were very few, 3% in the ISS, 9% in the LDH, and 25% in the FISH. That is quite expected because not in all patients the FISH is feasible. It depends on the quality of the bone marrow sample on which it is done. So these are very, this completeness is predicting a very good data quality of the data that we have collected. So that we sent at ASH 2019, and we provide an extended follow-up of the revised ISS, and as you can see on the right, and you can see that each of these prognostic groups have different survival. The survival are very different, so it seems like there are 3 different diseases. The revised ISS1 patient have a median overall survival of more than 10 years, while the revised ISS3 patients are surviving, unfortunately, only 36 months. But as we have seen before, the majority of the patients have an intermediate survival, but to me, it is unacceptable to have 60% of the patient in which you cannot tell what is the expected prognosis of this patient. What we have done also in ASH 2019 is to look at the single variables that are included in the revised ISS. So ISS 2 versus 1 and 3 versus 1 maintain their prognostic value, LDH as well, and high-risk the cytogenetics in the revised ISS is defined as the presence of deletion 17p, translocation 414, or translocation 1416. And as you can see in red, the value of translocation 1416 is not as strong as the other. So you can calculate the revised ISS also if you have not the result of the translocation 1416. So we started from here and then we move forward and we ask what are the prognostic factors that are not included in the revised ISS that can be used to improve it. So one of the most prominent factors that we found was amplification 1q. Amplification 1q is another another cytogenetic analysis that has to be done in all patients at diagnosis, and it can be used to improve prognostication because, as you can see, patient with or without amplification 1q have a different survival. The other things are quite expected, so performance status, creatinine clearance, and also IgA patients have a slightly lower survival than non-IgA patients. So we started from here and we tried to put everything together and to define a new prognostic score. So we ran an analysis on overall survival, taking into account the value of each of these single variables. And what we have found is that if you treat all these variables as single variables, the variables that are important in predicting survival in myeloma was ISS2 and 3, deletion 17p, translocation 414, amplification 1q, and high LDH. So as you can see, there are all the factors of the revised ISS, but amplification 1q is put instead of 1416. But what changes is the calculation of the score. So each of these factors have an independent prediction of overall survival. So if you have ISS2, deletion 17p, and high LDH, it seems like you have a risk that is deriving from the sum of the values of each of these variables. So if you if you give a score value of each of these variables, you can give to the single patient a scoring value that predicts his overall survival. And as you can see, if the patient is ISS2, it gets 1.3, 1.5 points, deletion 17p, 1 point, T414, 1 point, amplification 1q, 0.5, and high LDH, 1 point. So according to this scoring system, you can very well divide the patient according to their expected survival. And on the right, you can see the overall survival according to each 0.5 points of the score. So you have the best patient, that is the yellow one. They have a very good survival and do not have any of these prognostic variables. And the red one that have all of this and have a very poor prognosis. So in order to to create some groups that can be useful for the clinic, so we made some risk groups according to the total additive score, according to the classification in the previous slide, and we presented it at EHA 2020. And as you can see, patients that that have a total additive score of 0 have a very good overall survival and progression-free survival. And the patients that have 0.51 are low intermediate risk. The patients that are 1.5, 2.5 total additive score have an intermediate high risk, and from 3 to 5 have a high risk. What is important, and you see in gray the revised ISS calculated on the same patient population. So what is important is that these scoring systems allow to divide the revised ISS2 patient in 2 more groups, low intermediate and intermediate high, that have significantly different prognosis. And this is important because with this classification, you can identify half of the patient who have a fairly good survival and half of the patient that have not satisfying survival by putting together low and low intermediate groups and intermediate high and high groups. Okay, and as you can see, the first group, the low and the high risk group, behaves better or worse than the revised ISS1 and revised ISS3. So it seems that, like in this, with this new point-based model, you can improve prognostication and you can allocate better the patient to some risk groups. And this can be used to inform patients, but also to design new clinical trials on according to the prognostic risk of the patient. Because if you have 10% of the patient that are high risk, it's very difficult to design a clinical trial because this is a very rare population. But if you have 50% of the patient that have an unsatisfying survival, then this is going to be easier and can inform us better. And ultimately, the patient can benefit better from risk-adapted therapies. So the final model that we called R2 ISS, so the second revision of ISS, sorry for the riddle, but we had to give to the word some sort of continuous update of our prognostic score. So the first one was revised ISS, now it's revision 2 of the ISS, and we submitted it to ASH, and it's going to be a poster presentation in the Congress. So I want to thank Professor Hernandez, the key opinion leaders, and all the data owners that believed in the project and decided to share data in harmony. I can give you a quick update on what have been done in the last year and what is going to happen. Maybe we can start the discussion starting from this slide, if you agree. So I go quickly through it, maybe point by point, and ask if someone want to comment. I'm here, or maybe let's start with the question with the presentation. Then we go point by point on this point in the final slide to start the discussion. I hope that you heard me in these 15 minutes.
Yes, at least I could hear you very clear. I think it was a very good presentation. It summarizes very much the work done by EMN in Harmony in the last 3.5 years. I'm not a doctor. I'm not a patient, so I'm not very much familiar with what you are saying. But my understanding as a non-medical professional is that this will facilitate the selection of patients and it will facilitate also personalized medicines according to the risk. Is that correct?
Yes, this is what we wanted to achieve, because for now with RISS it's been very difficult because the majority of the patients are intermediate risk. So you don't know how to treat this patient. While with this score, you have half and half.
Okay, so one of the things that I would like to take the opportunity is that we have a patient, a myeloma patient representative here.
Yes.
How the patient community could help this study to be validated or to go forward?
So are there the representative of the patients? I think that I've seen someone.
Yes, so we're here.
Okay.
So no, my name is Ananda Plate. I represent Myeloma Patients Europe together with my colleagues Ana Vallejo and Julia Tolli. So I believe Ana, who's our comms manager, has some thoughts on this.
So I think that Santiago point is how the patient can be involved in this project.
For us, it's always good to be involved in this kind of projects. In fact, we've been involved also in the Delphi survey that is also part of this project. I think the best way for us to be involved in this is to be part of the design of this kind of studies, to see what is the best way the results of this study can help patients. So probably we can help with recruitment, giving the patient's perspective on that, and also being probably involved since the beginning in the design of the studies, and so we can help with the recruitment and well, having the patient's perspective in all part of the process.
Yes, I think that it could be once the score is validated, it could be a good idea to run some sort of survey or patient idea on personalized medicine and multiple myeloma, on risk-adapted medicine, I would say.
For sure, that is, I think, one of the areas of highest unmet need at the moment, as we hear from the patient community, what the preferences of patients are that live with high-risk myeloma. So I think that could be one thing, maybe even a patient preference study or something in that direction. We could think about how to design that.
Ananda, let me say also that low-risk patients are receiving therapy that is never ending. So I think that also the over-treatment, especially in patients' opinion, is a very good point.
Would be super interesting to maybe see the clusters that we can identify of unmet need, to see what those are in the different subsets of population of myeloma patients. I'm sure that the differences would be great.
Because as you can see in the slide, now the patient that have an expected survival of 3 years and the patient with an expected survival of 11 years are treated the same. And we have not the tools and the design trials to adapt the treatment on that.
Yeah, no,
and
absolutely.
We have now very good drugs that are going. We have data on a patient treated in 2010, but now we have a lot more drugs. So I think that in the future also the risk of over-treatment will be high for some subset of patients.
Yeah, so I understand half of what you said, but I think the important bits I captured, and I absolutely agree. And I think it would be good to gather some evidence on that. Also, I mean, yes, of course, the overtreatment of the lower risk or medium risk patients, but also the unnecessary treatment or treatment that isn't effective in high risk myeloma patients. We do see that you know, in terms of personalized or stratified medicine, that is one of the topics that comes up again and again, is like, yes, you're treating me, but still our patients we see in the community are dying like flies very quickly with treatment that all the other patients get, but you know, you see it's not working. And I think that's one of the greatest worries that also this subgroup of patients have, together with obviously the over-treatment of the patients you were referring to. I think it would be very good to get some evidence on that.
And also I would add also something regarding side effects, because as you say, there are a lot of drug combination right now. So patients are not being treated with one drug, but 2 or 3 or even 4 drugs. So it would be interesting to know how the amount of side effect of each drug is affecting the patients, especially in low risk, in those treatment, meaning those patients that are going to be treated for a long time, a very long time.
Can I ask you something?
Yes.
Can I ask you whether the collection of MRD data was part of the project?
Okay. No, at the beginning, because the most of these trials do not have MRD, because they were run between 2008 and 2014, and so the MRD started to be a standard procedure to do in the trials, maybe from 2013, 2014. So for the majority of them, we do not have other competing multinational worldwide data collection on focused on MRD. So it is difficult politically to have 2 worldwide projects or 2 European projects on the same line. Okay, so I was saying that MRD has not been collected in this project because there were other international projects already collecting it, and also because most of the trials that have a long follow-up do not have MRD data. We have response, but it's conventional response. So we have CR, VGPR, but not MRD. For some of these trials, MRD is available. However, we haven't still asked for it, but it's something that maybe we will do for the future.
If I may say, MRD is also of interest. I think that EMA is interested in MRD. Some of the pharma partners that are part of the Harmony Consortium are also interested in MRD. So this is one possibility of a future project if Mattia and the key opinion leaders in multiple myeloma in Harmony are interested in submitting it and in carrying it. But that's not part of the current work, but part of the future work in Harmony.
Yes, it can be. However, we have to do something different than what is being done in other big worldwide projects. Otherwise, it's not going to be supported by the partners.
Yeah, I understand that we cannot compete with other projects that are collecting MRD data in multiple myeloma, that we will have to find something different.
Yes, but however, it's something that can be done, but you have to have a different question, a specific question. Okay. So maybe adding MRD to the risk, to the baseline risk could be one. We first have to see how the multiple myeloma community will take this work.
And Mattia, how do you think that Harmony can help the myeloma pillar to validate the R2-ISS, and taking into consideration that Bill Wood from the ASH Data Hub is here, and also we have people from across the ocean that maybe also be willing to help in the validation. What is your proposal? And also, Bill, how do you think that the ASH Data Hub can help validate this?
For the collaboration with ASH Data Hub, I'm happy to announce that I know that the key opinion leaders of the two groups are in contact to design the first project, the first joint project.
Thanks very much.
And this will be in this will be on a long-term CR. Okay, I cannot see anymore the slide. Okay, yeah, now I can see. This will be on long-term survival of patients with CR, because with the new drugs, maybe we are starting to achieve very good results in the patient, and maybe a subset of patients can be cured. So it is a very good question to see if the CR patient, how they behave, and what is the optimal duration of CR in order to predict a long-term survival, because we have a lot of patient data, we have the response data, and it will be a very interesting question. So we are now writing a proposal to share with ASH Data Hub, as agreed between Professor Boccadoro, Professor Sonneveld, Professor Munshi, and we will circulate in the next few days. We have already, we are circulating it internally and then sharing it with the ASH Data Hub to add their part. And then I think that we will have to submit it to Harmony for the final approval. So do you have something to add?
Hi, everyone. This is Bill. I don't actually have too much to add. Thank you very much. This is a wonderful presentation, and I look forward to reviewing that document when it's circulated. I also wanted to acknowledge Kathleen Hewitt, Director of ASH-RC Data Hub, who's here with me as well. It's a privilege, obviously, to attend the Harmony virtual meeting. I think that, as you say, that there is clearly interest from ASHRC Data Hub in collaborating with Harmony. We have resumed, as you say, conversations and discussions and joint and intention to conduct joint projects. We've been spending a lot of effort developing our networks of contributing sites and our structures so that we can efficiently bring in and analyze real-world data. So I think that there are some natural areas of working together here, and we'll look forward to continued conversation, reviewing the proposal, and seeing what the best approach is for joint projects moving forward. Thank you.
Yes, thank you, Bill. Can you give us a brief update on what are the timelines for ASH Data Hub to start to include patient data?
Yeah, I think honestly that is somewhat to be determined. We're in the process of bringing in data now, but I do think that we'll want to settle on that initial question. I know that in the past we have talked about looking at those patients who are having exceptionally short periods of progression-free survival, and then the patients, as you've just pointed out, who have particularly long periods of remission. And the two types of perspectives have different requirements in terms of real-world data to answer those questions. So I think before committing to a timeline for when we'll have those data available for analysis, we'll want to look at that document, make sure that we're all aligned on the next best steps, and then we can talk about kind of what we think would be realistic in terms of trying to work together on a shared project.
Okay, and are you going to include real-world data only, clinical trial only, or mixed types of data?
So our emphasis so far has been on real-world data collection. We do have data from closed clinical trials as well, but and I think again more to come there in discussion. But a lot of our focus is on real-world data to generate real-world evidence.
So returning to the question by Santiago, Santiago, I think that what Harmony have to do now is to improve the collaboration from FPA partners, because as we shared our concerns from this, we have now 3 years now that we asked for some very old trials, and we still cannot, we still did not have it in the platform. So I think that this is something that we can get better, and we
lost you again.
To ask FPA. Yeah, I know it's difficult, but it's a PPP, so we have to involve them, and and also they have to give some some relevant data, because if they share only the some non-active arm, some old trials, is not going to be useful nor for the community and nor for eventually for the patients.
I fully agree with you, Mattia. I mean, believe me, no one knows that better than me, who is running after the FPA partners to get some data into the platform. As I told you, we have some old trials from Janssen. The problem with that is that it's taking longer than expected to harmonize them to a mock. We also should have the Celgene trial, the first trial, but it's also taking longer than expected because of the merge of Celgene and BMS.
BMS and Celgene, yes.
And please let us know what trials you need so we can ask for them and try to negotiate that, because it's been hard for the project even to get that data inside the platform.
Yes. Thank you. Yes, I will let you know if we will need maybe for some other questions, some additional trials from FPA. But I mean, for newer trials, it will be more difficult, in my opinion. For all trials, it should be easier, but however, maybe when we will start will be easier. Let's hope this. So I think that we can go through this point briefly. So these are the abstracts that we produced. The data analysis team was a joint data analysis team of, between EMN and Harmony. And from EMN, we have our statisticians from EMN Data Center, and from Harmony, we have Gastone and Daniele Dall'Olio, who helped us to adapt our R script with the platform and with the OMOP structure. And in the last year, we did the data intake of the EMN O2 trial, and we have an ongoing discussion with the UK. And our plan was to validate the R2 ISS with these data, and then if FPI is going to take much longer, to try to publish the first manuscript. We think that with the 7,000 cases in the training set and the validation in the UK data, it could be sufficient to get a good scientific publication to publish the R2 ISS data. And as I told you, the new projects are being wrote, and the most important and the project that is almost ready is that on long-term survival with CR with Hash Data Hub. And of course, I pointed out that maybe in the future, new data and new data sets are very welcome. And these are the what we are lacking now. We are lacking FPA data. We are lacking data on monoclonal antibodies combination and second generation PI. But, these are difficult to get now, but in the near future, maybe when all the publication on monoclonal antibody combination are out, we can ask for the inclusion of these trials. And of course, we can ask for new data with new questions. So just a few ideas. The number of copies of 1Q can be important in definition of the risk. The clonal cell fraction of deletion 17p and the presence and the co-presence of TP53 mutation. So we are lacking now FPA data, monoclonal antibodies combination data, second generation PI, so carfilzomib will be used in first line. And we are lacking some data on the number of copies of 1Q that can be important, the clonal cell fraction on deletion 17p, TP53 mutation, and as it's been pointed out before, MRD, but we have to find some specific question to collect MRD to not overlap with existing worldwide efforts.
One question, Mattia.
Yes.
Up until this moment, all the data in multiple myeloma has been collected via EMN. And
yes.
Is there a possibility, or do you foresee that we can also help you with this collection of data? I mean, in case that some institutions are not part of EMN and you want the project directly to contact them and to put them in contact with EMN for the collection of NGS data as the TP53 mutation of the other data that you are mentioning in your last point. Do you?
Yes, of course. Of course, we did.
No, go ahead.
So we did through EMN because they were trials run by our partners. But if it is a non-trial or it is a trial with this, sorry, maybe you lost me. Can you hear me?
Yes.
Can you hear me?
Yes.
Okay. So if it is not a clinical trial run but an EMN partner, of course, it is feasible to transfer it directly to Harmony and to analyze.
The reason I'm asking you is because we have contact with some registries that they may be willing to transfer some multiple myeloma data, and it may be of your interest. But maybe this can be discussed outside of this meeting, and we can see if this data will be of interest for this MM project or for future MM projects.
Yes. I think that also the owners of the data can write some projects and this can be circulated to the key opinion leaders in order to see if it is of interest. Of course, for each new project, we have to ask data owners if they are willing to share the data for that question.
Yeah, I understand.
But I mean, out of the 7,000 cases, a lot of patients are from trials run by the key opinion leaders. So once they agree, I think that the project can be run.
Mattia, thank you very much for your participation, your willingness to update us on the current multiple myeloma project. We look forward to receive further questions for evaluation, and please do not hesitate to contact us or to contact the people who are attending this group. I mean, people from the Ars Data Hub, patient representatives, for anything that can be of help to further this project at the moment and the next projects.